clinical atopic dermatitis that has resulted here in hypopigmentation, but you never really see that acute eczematous dermatitis in these areas. And this tends to respond just to plain old emollients and tends to improve as time goes on. Other associated features include hyperlinear palms, so that's what we're looking at over here. And this is simply more lines on the palms than you would expect in a non-atopic person, hyperlinear. And then on this side is a patient with keratosis pilaris. So these are follicular-based pink spiny papules on the backs of the arms, although another common place to see them is on the thighs and also on the buttocks. Patients a lot of times describe this as feeling kind of like chicken skin or like goosebumps. There are also some variations on the theme when it comes to atopic dermatitis, and one of those is hand dermatitis. So what you're looking at here is an adult with a rash just limited to the palms of the hands, and in adults, hand dermatitis has atopic dermatitis as part of the differential diagnosis. Contact dermatitis is also in there, and also psoriasis can be limited to the palms. But again, instead of that classic flexural distribution, sometimes limited only to the hands in adults. It's not without complications. So the patient here is one with eczema herpeticum, and this is a circumstance where a patient develops an HSV infection, and instead of that being limited to just maybe a cold sore like herpes labialis, they go on to have involvement of all of their skin that has atopic dermatitis, then develops HSV lesions. So patients can get widespread cutaneous herpes simplex viral infection. And then on this side is a similar scenario, except this is with smallpox. So patients develop eczema vaccinatum when they have active smallpox, and they also have atopic dermatitis. So this is a good reason why people who are active military, active duty military and have atopic dermatitis should not get a smallpox vaccine, because they can develop eczema vaccinatum. So the main things in terms of taking care of these patients, the most important thing is maintenance. And the best way to do that is by keeping the skin moisturized. Patients shouldn't stay in the bath or shower for more than 10 minutes at a time on any given day. And you need to stress to them to get a good moisturizer on as soon as they get out of the bath or shower. The things that work best are ointments, which don't have any water in them at all. So plain old petroleum jelly is really very effective. And then the next best thing are creams, as opposed to lotions or oils, which tend not to be as lubricating as creams are. And of course, you want to avoid anything that might potentially be irritating, like fragrances or wool, or even detergents like excessive washing. Aside from maintenance, after that, for acute flare-ups, topical corticosteroids are really a mainstay of treatment. Depending on the location and the severity of the eruption, that's going to help you determine the potency and also the vehicle of the topical corticosteroid to use. Also the age of the patient plays a role in trying to determine that too. And then topical immunomodulators, so that's things like tacrolimus or pimecrolimus, can be a helpful part of treatment, not quite for maintenance, but definitely for disease that is not as severe. So for kind of mild flare-ups, that's when those immunomodulators might play a role. But when patients are in a more severe flare, then a corticosteroid really is going to be your mainstay. And then occasionally we have to use systemic therapy, so systemic immunomodulators, medications like cyclosporin, and other treatments that can be used on the entire skin without being taken internally, like phototherapy. Narrowband UVB is sometimes used, and also PUVA, which is psoralen plus UVA light. So the same information in a different way to look at it. Here at the base of the pyramid is skin care, and irritant avoidance. So that's the moisturizing things, the maintenance stuff that we already talked about. And then the next thing is going to be the topical corticosteroids, and then systemic therapy right there at the top of the pyramid.